Hello, today we are going to talk about rhabdomyolysis, which means disruption of muscle secondary to muscle injury, and it's a medical emergency because the patient can die due to hyperkalemia or DIC. So, the case scenario will present a patient who is doing a lot of exertion, for example, an athlete or a marathon runner, or a patient affected by a crush injury due to road traffic accident, or he has been trapped under a heavy object, for example a tree or a truck, for a long period of time, or patients with severe electrical burns or heat strokes, or patient who are immobilized for a long period of time, for example in alcoholics or drug users, or a patient with stroke, or the patient who is diabetic hypertensive, has ischemic heart disease and has been taking simvastatin or any statins for a prolonged period of time. So or patient can also present with a complication called as a compartment syndrome secondary to RTA or any orthopedic surgery. So the mechanism is that muscle injury or ischemia, it will disrupt the sarcolemma of muscle myocyte, and then after disruption of sarcolemma there will be a release of myoglobin, CPK, and potassium, and that myoglobin, it normally binds to haptoglobulin in the plasma, but when excessive amount of myoglobin is produced, there won't be enough haptoglobin for bind to it, so that myoglobin will release into the urine and it will precipitate in the tubules, and it will undergo oxidative damage, or it may precipitate to form cast, and those casts will cause direct nephrotoxicity, direct oxidative damage to tubules, and that will result in acute kidney failure or AKI. And now we will go towards investigations. First, we would like to perform an ECG because the patient will die of hyperkalemia. So the hyperkalemia ECG is like this: small P waves along with broad QRS and tall tented T waves. If you have this kind of ECG, you should immediately start patient on calcium carbonate or calcium gluconate, calcium chloride, whichever is available, and then you will go for RFTs to look for patterns of AKI and urine analysis. Now the myoglobin is red, so urine will appear red, but it won't have any RBCs on urine analysis. Then we will go specifically for CPK levels, creatine phosphokinase levels. Creatine phosphokinase is found in kidney, in brain, sorry, not in kidney, only in muscle, brain, and heart. So any kind of injury to these three organs will raise the levels of CPK, but CPK levels are very sensitive but not specific to muscle injury. You will have to correlate clinically. If patient has and stroke or myocardial infarction, CPK levels can still rise. And in this case, due to extreme and severe muscle injury, there will be 4 to 5 times increased, and then of course serum electrolytes to check for hyperkalemia. So treatment would be to stop the drugs. For example, if patient is taking statins, we monitor patients who take statins for hepatotoxicity and for rhabdomyolysis. In this case, patient will present with severe muscle pain and dark urine, and then you will have to do urine analysis, and when you confirm it by urine analysis, you should stop the drug. And if it's an athlete, we will advise him to go for low intensity exercise, and in this case, for example, he should stop exercise for a couple of days. And then if patient is presented to ER after RTA or whatever, we will first management will be plenty of hydration, because And myoglobin cause vasoconstriction of renal vessels, and due to vasoconstriction, pre-renal azotemia, pre-renal injury also develops. So we want to avoid that. We will give patient plenty of IV fluids, um, and then we will, of course, we will go for calcium gluconate and chloride to prevent heart from getting arrhythmias, and then loop diuretics, because and mannitol to wash away all the crystals and casts that are present in renal tubules, so that we can avoid further damage. And that's it. Important point to remember is that compartment syndrome can cause rhabdomyolysis, and rhabdomyolysis can cause compartment syndrome, and usually patient will die because of DAC and hyperkalemia. That's it.